Sorry,
after that,
can I?
yeah, and after that, Dr. Milind Pimprikar will speak on the his experience of Osgood-Schlatter disease, and then we are going to have three case-based discussions.
Okay.
Yes.
Sorry,
Yeah,
can you? I'm trying to share my screen.
Can I start?
Sorry, I'm trying. One moment, sorry. I'm trying to share my screen, but it tells me that host has disabled participant screen sharing.
Yeah, it'll happen now. Once we are live on YouTube, it'll happen.
Okay.
Because everything is linked to the YouTube now. So can you check it now, Nicola?
Hold on.
Yeah, we are live on YouTube now.
Yeah. Okay, fine.
Okay.
I'm going. Okay.
Today's topic is jumper's knee. Often talked about as patellar tendinitis, but because this term was coined by Martin Blazina in 1973, a lot of research has gone over it, and we know now the cause is not only in the patella, the size of the patella, fat pad, patellofemoral joint, plica, tendon, retinaculum, paratenon, and muscles around, and even corticospinal activity. Today's speaker to tell us about this is none other than our good friend Dr. Nicola Mafulli, who has written over 200 scientific papers on tendinopathies, and in my opinion, he should be called like a father of tendinopathy. So over to you, Nicola.
Thank you very much. It's very kind. It's very kind to have been introduced by Dr. Antau, and I'm very happy to be here again with you. As you all know, I love India, and I wish I could be there in person because I always enjoy coming over. Today, I've been tasked to talk about patellar tendinopathy, and I bring you the best regards from ISMOT, the Italian Society of Muscles, Ligaments and Tendons. I don't know if you're aware of it, but we started the society in 2010, so it's been 10 years now, and we've been very active in the field of muscles, ligaments and tendons, branching out as well on joint pathology as of late. At present, I'm based in London, physically in London, simply because I've been stranded here since the 5th of March. My substantial chair is at the University of Salerno, and it is an interesting story because most of you will know that Bologna and Padua claim to be the two oldest medical schools in the world. Let me tell you, they are not, because medical schools started in Salerno, in the southern part of Italy, in the 9th century after Christ. The teaching, unfortunately, was stopped by the brother-in-law of Napoleon in the 1820s, when southern Italy was part of the aegis of Napoleon, and Gioacchino Murat, who was the ruler in that time, decided that the University of Study of Salerno had to stop teaching medicine. Eventually, about 15 years ago, teaching there started again, and now the University of Salerno is one of the top small universities in Italy. I'm also still associated with Barts and the London School of Medicine and Dentistry, where I was a professor in orthopedic sports medicine until I went back to Italy in 2013. And I also hold an honorary professorship in one of the other universities where I was the professor of orthopedics and trauma before moving to London. We've been extremely active in tendinopathy research, as Dr. Antau was reminding us, simply because it's an area where not much is known. If you look, let's see, yes, this is one of the books that we published on tendon injuries together with Per Renström, who is now retired but was the professor of orthopedic sports medicine at the Karolinska Institute in Stockholm, in Sweden, and Weldek Better, who is based in Baltimore, is now retired from surgery, but is one of the great thinkers in orthopedics in our world. If you look at tendon problems, we can think about them in different ways, at different levels. We can look at human studies, animal models, and eventually cell models. Now, today, I'll mainly concentrate on the human aspects of tendinopathies, but from a research viewpoint, we have used some animal models at the time, and we are very, very active in the lab on cell models. And you will find, if you do a literature search on PubMed with my name, you will find that every year we expand on the basic sciences of tendinopathy. Now, we all know that tendinopathy is a syndrome. It's a syndrome composed of three things, three mainstays: pain, tendon changes, and decreased physical ability. We all know that this is the case, but please remember it's very much like a black box, because what we see is only what we know. And we know that patients present with us with pain that induces decreased physical abilities. And when we image those tendons, we'll find that a good percentage of these patients have tendon changes evident at imaging in terms of ultrasound scan and MRI scans. Now, this is the so-called tendinopathy circle. This was worked out by Ledbetter in 1992. It is 30-year-old, but it's still a good depiction of what may happen. And it reflects very much what was happening, the knowledge of the time. Originally, we know that the increased demand of the tendons may induce adequate repair and adaptation. And in that case, we're home and dry. We don't go anywhere else. The patient is not a patient, remains an athlete, remains somebody who is able to perform at a relatively high level. However, there could be inadequate repair with inadequate collagen and extracellular matrix production. If this is the case, then the metabolic machinery of tenocytes is disrupted. And if this takes place, then there is further alteration in collagen and matrix production, which predisposes the tendon to further injury, and there is therefore a positive feedback loop which perpetuates the status quo and increases the chances of those patients becoming symptomatic and never healing. At present, we're, however, exploring some different paradigm. So, if training overload is imposed on the tendon and there is increased matrix synthesis, increased extracellular matrix synthesis and hypertrophy, relative hypertrophy occurs, then again there is no problem. But what may happen is that there could be, for example, poor blood supply to that area, which induces cell damage to the action of hyperthermia, free radicals, hypoxia, and in this case, therefore, the microdamage couples with it, and extracellular matrix fading response occurs. Now, the classical, the paradigmatic example of tendinopathy is just this: is the extracellular matrix failed healing response, a lesion which tries to heal, but for some reason does not, healing does not occur. If this is allowed to progress and continue, at times even in a totally subclinical fashion, then mechanical loading is applied to this failing response and eventually a rupture occurs. When we look at tendinopathy, we don't necessarily reach the right picture. If you think about it, at best, we see patients here when symptoms occur. I see patients, unfortunately, down here. I've always worked in teaching hospitals in tertiary referral centers, so I see complicated patients where a whole host of unknown factors have contributed to the onset of symptoms. If you think about it, there are a lot of unknown factors that have occurred before the patient becomes symptomatic. And in this respect, therefore, a tendinopathy, which is clinically acute, in reality, from a biological viewpoint, is a chronic injury already. We talk about risk factors, we talk about intrinsic and extrinsic risk factors, we talk about the role of injury and overuse, and as of late, we are starting to talk more and more about metabolic disorders. We spoke about it last week when we're talking about the Achilles tendinopathy syndrome, and we're talking about how these symptoms can be associated with diabetes, with lipid metabolism type of disorders, and with disorders of the genome and the microbiome. What we do know, however, is that in this field there is an enormous confusion, and the confusion comes from the very beginning. So much so that more than 20 years ago, together with Karim Khan, who is now the editor of the British Journal of Sports Medicine, and Giancarlo Puddu, who in 1976 published a seminal paper in the American Journal of Sports Medicine, we decided that we had to sort of uniform the terminology in this field. Therefore, we started talking about tendinopathy, the main body of the tendon, tendinopathy, the surrounding tissues, such as a paratendinopathy, for example. If both the main body of the tendon and the surrounding tissues are involved, then we speak about a pantendinopathy, and we acknowledge that insertional tendinopathy and ruptures are totally different beasts. Consider that in most of the tendinopathies of the body, of the human body, we're really talking about insertional tendinopathies. If we think about, for example, even rotator cuff injuries or tennis elbow, and in this case, patellar tendinopathy, these are very much tendinopathies that occur at the insertion between the bone and the tendon. And the classical site of tendinopathy in the patellar tendon is the attachment between the lower pole of the patella and the patellar tendon itself. The next speaker will talk about Osgood-Schlatter, and in that case we have a traction apophysitis of the patellar tendon when it inserts on the anterior tibial tuberosity. One of my old bosses, now defunct unfortunately, John King, and I described a tendinopathy at the main body of the patellar tendon, but this is a very, very uncommon presentation in this field. We have no doubts that patellar tendinopathies are difficult to manage. The management is often anecdotal. It is very rarely evidence-based. It is very often emotional. And if you use the Occam's razor of dissecting the biological facts and the scientific facts about tendinopathies, we will find that many treatments are at best only dubiously effective. Also, think about many patients are extremely emotional. They've had tendinopathy for a long while, but they come over to us because they want something done sort of now. One of the big problems is that we don't know where the pain originates from. There are theories of pain, but there is no hard facts. We talk about tendinopathy being associated with increased vascularity, and that is true, but the vascularity in and by itself is only associated to pain. And if we look at the histology in that area, we'll find that the real cause of pain and probably of the perpetuation ad infinitum of the failure in response, which characterizes the tendinopathy syndrome, is the fact that with the neovessels, there are a lot of neonerves which carry drawn signals to and from the tendon. However, if we don't know where pain is coming from, therefore, we do not know why and how any therapeutic modality, including surgery, really works. There are some traditional perspectives. The traditional perspective is that the tendinopathy is self-limiting, it is inflammatory, and therefore it's a tendinitis, that imaging can be used to management, that conservative management can be effective, a shot of corticosteroids, well, everybody does it and does no harm, and that surgical management allows return to competition in around 3 months. But let me tell you that these are traditional perspectives, and very often tradition is only ancient error, because none of this is in and by itself true. We have omitted from our terminology, as you've seen before, the term tendinitis, but we acknowledge that over the course of the last 10 years or so, we are concentrated a bit more on the effect of inflammation and tendinitis. These are 2 editorials that we published a while ago, looking at whether there is enough scientific truth and evidence for the conservative management of tendinopathy, and to show how eccentric exercises worked in tendinopathy. The mainstay of the conservative management for patellar tendinopathy remains eccentric surgery. Very interesting paper that Roald Barr from Oslo in Norway and Lasse Gebretsen published in the JBJS American about 15 years ago looked at the randomized control trial where patients at presentation were randomized to either have a cycle of 3 months of heavy load eccentric therapy or being operated straight away. So this is a very uncommon type of management in that we will not probably offer surgery straight away to our patients, but we would offer eccentric exercise. What they show is that in the medium and long term, there was no difference between groups. Therefore, surgery does not play any real role in the early management of patellar tendinopathy. And I very much suggest that patients at presentation should not be operated straight away. In that respect, therefore, be aware that there are no indications essentially for surgery in patients who are just being referred for patellar tendinopathy. Can we do other things? Yes, we can. We can use, for example, radial shockwave therapy. And this is a paper that marries our American, Italian, British, and German experience. And we showed in these patients that a single application of radial shockwave therapy at high energy is effective for chronic patellar tendinopathy. Can we use platelet-rich plasma? Yes, we can. However, beware, because the evidence is not really that clear-cut. It is possible that leukocyte-rich patellar PRP does play a role, but if you look at a very elegant paper published by Fred Defoe, Chris Harner, and a group from Europe, it shows very clearly that in patellar tendinopathy, the injection of PRP can actually be detrimental and not only cause more pain, but induce thickening of the patellar tendon and even rupture. So beware of what to do. We have dabbled for the past 20 years with high volume injections at the interface between the Hoffa's bodies and the patellar tendon. If this is the patellar tendon and this is the area of tendinopathy, you will see that there is an area of neovascularization and neoinnervation. In this area, we insert a needle and we inject up to 60 milliliters of high volume fluid. And in this way, as is shown in these sequential pictures of a power Doppler, this is a very thick Achilles tendon with evidence of neovascularity. This is the needle being inserted in that area. And after this large volume of fluid has been injected, you will see that there is no neovascularity any longer. However, please remember that we don't target the neovascularity in and by itself. In reality, the neovascularity is a sign that something is happening over there, and we target really the neonerves which accompany the neovascularity. There is a lot of talk nowadays on orthobiologics and the role of modern therapies based on cell-based approach. It is a potential area of treatment, and together with Isabel Andia from Spain, we looked at what had been written in terms of use of mesenchymal stem cell therapy. And these are this is a list of NFL patients who have received stem cell therapies over the course of the last 10 years or so. And you see that obviously the NFL is a highly paid, highly stressful environment, and these patients want to be better soon. You will see that they have received these injections, some of them in the States, some others in South Korea, Switzerland, and so on. The future may well be that we may be able to harvest the potentialities of resident stem cells in tendons. And together with my group in Italy, we ascertained how tendon stem cells could be harvested from adult human tendons. This is a study performed in the tendons harvested for reconstruction of an ACL. Therefore, they were either semitendinosus or gracilis tendons, and we managed to find stem cells, tendon-derived stem cells in these tendons. However, as we age, we find less and less number of these cells. Therefore, beware, because as we get older, our capabilities for regeneration I guess less. Nevertheless, there are stem cell treatment clinics just about everywhere. And the message, which has been very clearly expressed in a great editorial last year in the JBJS American first, and then reprised by the American Journal of Sports Medicine, is that we really cannot be sure of what we are injecting given the variety of sources of so-called stem cells and what we end up doing with them. There are many unanswered but legitimate questions on what to use in terms of adipose-derived stem cells, blood-derived stem cells, bone marrow-derived stem cells, and so on, where from, whether they should be generic or autologous and so on. We are not sure of when to inject them in the disease process. We are not sure how often we should inject them and for how long. I'm a surgeon, however, and I get referred these patients because a lot of treatments have failed and this patient wants to do something, wants something done. And in general, I undertake surgery after 3 to 6 months of well-planned, well-performed, and well-adhered to conservative management program. Therefore, I have to make sure that my patients have seen the right physiotherapist and the right rehabilitation specialist, that they have been prescribed the correct management and that they have adhered to it. Unfortunately, there are no validated surgical protocols, and this is just a list of procedures that have been described for patellar tendinopathy. So you can go by open patellar tendinopathy or arthroscopic osteotomy, adjunct procedures, ultrasound-guided percutaneous tenotomies, which we described. Some people end up harvesting polycystic tendon graft. But the aim is very simple. The aim is to promote repair and to return the patients to pre-injury activity levels. And if you think about it, it's a classical orthopedic operation because I don't really know what it does, but I use a bigger scalpel with a heavy hammer and eventually things go well, maybe. I use the Kisso principle because I want to keep it simple for the simple orthopods. And when we look at what we're doing, we manage to have a very specific sequence of what we do. We place the patient supine, we apply a tourniquet to the root of the limb inflated to 250 to 300 millimeters of mercury. We mark the area of pain and we perform a direct midline incision over the patellar tendon, normally extending 3 to 5 centimeters. We expose the tendon and we excise the palatine, and then we separate the tendon from the Hoffa's body. We undertake 3 longitudinal tenotomies along the longitudinal axis of the tendon and palpate the area, identify the area of tendinopathy. We then excise it and we send it for histology. We leave the lower pole of the patella alone unless it is very prominent. We undertake a very abundant washout and the accurate hemostasis. We close separately the subcutaneous fat and the skin, and we bandage a lot. I allow patients to weight bearing immediately, and we discharge them as day case. And then that's probably the most important thing because, well, this is what we do. We very often undertake an arthroscopy to make sure that there is no other intra-articular cause of pain. We open the area. These are the tenotomies. And then eventually we end up praying, because probably praying is the most significant, the better thing that we can do, given the fact that these results are only partially predictable. Remember that not everything goes well all the time. For example, well, these are all, I put my hands up because these are all my patients, okay? But consider this is the same operation performed on the same day on 2 knees. I did exactly the same thing, okay? I did exactly the same thing. And one side is beautifully healed at 2 weeks. The other side has an area of delayed healing and diastasis of the wound. This is a few weeks later. You can see here that diastasis of the wound is not at all infrequent. This an African Caribbean patient. You can see that in these patients, hypertrophic scar and keloids are very common. And this is a problem because this area over here now will be fragile and will be prone to breakdown. Whatever you do, however, do not ask for plastic's opinion, because even these angry-looking wounds will eventually heal by themselves with a decent thing. We have described ultrasound-guided percutaneous longitudinal tenotomies. These date back, imagine, 21 years ago. We've been doing them for a quarter of a century. We can identify the area of tendinopathy, and we can introduce a scalpel blade percutaneously to a single stab wounds, and we can perform a longitudinal tenotomy that way. We can do the procedure arthroscopically. This is what we've done, indeed, and I studied, part of my fellowships were performed while I was in Melbourne in the late 90s. And in Melbourne, there were two groups. One were doing arthroscopic surgery, the other one open surgery. And I imported to some extent these techniques over in Europe. However, in Melbourne, the person who was doing them arthroscopically has stopped doing them arthroscopically and has gone totally to undertaking them in an open fashion. We describe the long-term result for arthroscopic procedures, and in selected patients it does work. However, I'm seeing more and more patients who have been operated in an arthroscopic fashion in whom the procedure has failed. And I've changed totally now my philosophy of management. Although I like minimal invasive surgery, and I operate essentially on all these patients in an open fashion. This is the study I was referring to. This is good old Artie Coleman, who was my student in the early part of this century. He's originally Australian, and he looked at these two groups in Melbourne, where one group were undertaking open surgery, the other group arthroscopic surgery. You can see that although symptomatic benefits were more evident in the arthroscopic group, the median VISA P-score, which is a PROM, a patient-related outcome measure, was lower in the patients undergoing arthroscopic surgery. So in the end, there was no difference in outcome between the types of surgery. And this is what really has prompted me to go back essentially to undertaking this procedure in an open fashion. However, when we deal with these patients, we have to manage expectations. The return to sport is long, and a realistic rate of recovery is not 100%. It only ranges in the region of 70 to 85%. This is something that we have to tell our patients. We have to educate our patients in this respect. In our hands, with the average true recovery time after patellar tendinopathy surgery is 9 months. Don Sheldon, who is the father of accelerated recovery for a vast variety of knee surgeries, including ACL and including patellar tendinopathy, has implemented an accelerated rehabilitation regime for patellar tendinopathy patients. And in his hands, accelerated recovery following the patellar tendon surgery results in an average return to sport of 8.1 months, which, allow me to say, is not the difference from the 9 months that we experience when they take traditional rehabilitation. Unfortunately, the most common cause of failure following surgery, when the surgery has been well performed, is attempts at early return to sport. And this is something that you have to tell your patients, because if a patient is promised that they will be able to return to sport in 3 months, they will try and do so. And in this doing, they will destroy all the good work that we've done as surgeons. 9 months, remember, is realistic. 3 months is not. We're going now towards the end of this presentation. And I thank you very much for having been patient. The bad news and the take-home messages is that in most instances, PRP or mesenchymal stem cells, the orthobiologics which are so much in vogue at present, are not better than placebo. The good news is that saline injections are more or less always as good as PRP. And if you really don't like somebody, inject them with corticosteroids only, and you will find that they will be grateful for a while. But if you wish to know more, please have a look at the journals of which I'm an editor. MLTJ, Muscle Ligament Tendon Journal, is a free journal. It's an open access journal. The website is mltj.online. But in the end, it's been, as per usual, a great pleasure being with you. There's still a mountain to climb, but slowly and painfully we are getting to the top. Only as we are progressing, I remember that I've met many of you when we still had hair, and we still had some dark hair. Now many of us have lost hair and have some gray beards around. Slowly and painfully, progress is being made, but less and less of us are staying on the road. Thank you very much.
Thank you, Nicola, for the wonderful lecture.
Can you just take us, Dr. Nicola? Yeah. Can you just take us to a real time?
Sorry, I can't hear you properly. Sorry.
Can you take us to a detailed clinical examination and the type of history that you will ask in this kind of patients?
Yeah. Normally, these patients are jumping athletes. So the most common sport that we find in the UK are essentially netball, which is what you know what netball is, basketball, which is less practiced than netball nowadays, and volleyball. However, more and more we're seeing that football players are suffering from this, and high jumpers and long jumpers are suffering from patellar tendinopathy. A change in habits in terms of introduction of plyometric exercises and a transition between concentric and eccentric work can play a role, and therefore make sure that you ask this to all your patients. The patients will typically present with pain at the lower pole of the patella, and with the test, the clinical test that we perform in these patients is the Royal London test. If you go onto MLTJ, you'll find that the test has been described by us and by John King. We ask the patients to lie supine on the couch, and we palpate the area of tendinopathy. In the patients, when we palpate the lower pole of the patella and the soft area at the lower pole of the patella, the patient sort of jumps off the couch. You then ask the patient to flex the knee to about 60-90 degrees, and you palpate the same area. And if the pain disappears or is grossly diminished, then that patient is likely to have a classical tendinopathy. And this is confirmed very much by imaging in terms of ultrasound or MRI scan. If it doesn't go away, then you must explore other things. For example, the patient may have a combined paratendinopathy and tendinopathy, or one of my fellows, Francesco Franceschi, described an Ethiopian runner who had signs and symptoms of tendinopathy with an imaging picture very reminiscent of tendinopathy. But when they operated on him, they found out that he had TB, tuberculosis located in that area. This really case report. Please remember that the TB is coming back even in the West, and so it's something to keep in mind. Last week, speaking of Achilles tendon problems, I told you that we encountered, together with some of my fellows in Brazil, patients in whom pain at the insertion of the Achilles tendon was a sign of HIV positivity. So beware of that as well. To my knowledge, it has never been described in patellar tendinopathy, but it is a possibility. You have to exclude when you examine these patients that they have intra-articular derangement of the knee. Therefore, always perform tests in terms of McMurray test, Lachman test, and so on to ascertain that there is no meniscal pathology or no combined ligamentous and meniscal pathology. Dr. Shah, you wanted to ask?
Yeah.
So, I think that Dr. Shah wanted to ask something.
How often you ask for Blazina's criteria? Are they very relevant now?
I don't particularly use them because I use the VISA-P. The VISA-P is a chrome. Blazina, obviously, Blazina stages were very practical in the 70s, but were probably progressed from there. The VISA-P, if you are comfortable and familiar with it, is a straightforward scale where you can assess the degree and you can actually give points to that condition. In general, patients who present patellar tendinopathy are able to function fairly well down to a VISA-P of about 60, and with a level of pain, a scale of 0 to 10, with 0 being painless and 0 and 10 being totally the worst possible pain that they can experience. Up to a level of 4, I tell them that they can essentially go to the Olympics. And I've had patients who are at the level of 2 and they won Olympic medals. So they can function still at a very high level that way. With the VISA-P, you can actually quantify whether they're getting better, they're staying the same or getting worse. And what we have found is that the level of increase in when they improve, a clinically relevant improvement is characterized by a change of 20 points on the VISA-P scale.
Do you you mention about one test? How does it differ from Gassett's test? Bassett's test.
Bassett's test is just palpation, isn't it? This one, the Royal London test, is palpation in 2 positions of the knee, with the knee extended and then with the knee flexed.
This point of tenderness is all along the tendon or only at the origin of the patellar tendon?
Only at the origin of the patellar tendon, at the point where it attaches to the lower pole of the patella. That's the classical site of patellar tendinopathy. As I told you, there is a subpopulation of patients, which is however very small, probably only 1 in 20, 1 in 25 patients, who presents with tendinopathy of the main body of the patellar tendon. But this, we don't know why. It is the equivalent of tendinopathy of the main body of the Achilles tendon. We have a relatively small series of patients, only out of, I don't know, 600 patients that I've operated on, only about probably 25, 30 have been with tendinopathy of the main body of the patellar tendon.
Nicola, what is
there was Dr. Shah wanted to ask a question.
Yeah, Nishit, I think Nishit has probably internet problem. He'll join back. Sorry. So I just wanted to ask, what is the natural progression or natural history of this patellar tendinopathy in elite athlete? I'm not talking about the general population who are not involved in any of the sports. So how does it go?
In general, while an Achilles tendinopathy can present in the general population, patellar tendinopathy develops in jumping athletes. The general population does not suffer terribly much of patellar tendinopathy. In general, patients who are not treated, are not sitting well, they just get pain and they cannot perform at the same level that they were before. So top performance is sort of negated to them. There is not much evidence that the tendinopathy will continue to evolve until a jump will cause a patellar tendon rupture. However, if they are injected with corticosteroids and the pain is taken away and they go back jumping, there's a higher chance that they will rupture the patellar tendon. And if they rupture, well then it's a major problem because they will need surgery. And the return to sport following patellar tendon rupture is a bit more troublesome than we think it is.
Yes. Dr. Shah, Nishit Shah.
Yeah. All right.
Hi.
Nishit?
Yeah. I don't know experience of my other colleagues, but though our society is a squatting type of society and a lot of people just sit on the ground, we are not seeing so many patellar tendon and tendinitis. What can be the reason?
But I think the lifestyle does play a role. Now, I've seen, we just finished a study with a group of Russian orthopedic surgeons where we studied the effects of Sala the Muslim prayers in elite professional football players. And what we showed there is that that these players have a lower incidence of essentially biceps femoris injuries. Okay, it is possible that the slow stretching and eccentric contraction, which are required of same prayers 5 times a day, may exert some good effect on the musculoskeletal tissues of the lower limb.
No, it is. I'll just add to Dr. Nishid, because it is a good observation. It may not be seen in a younger or older population, but it is surely seen in the school-going children, especially people who are involved with Sports Authority of India and who play in jumping and all this. I have seen many patients of patellar tendinopathy in my KM hospital. We get a lot of patients, especially the young. It is not at all the disease of the old. When we talk about tendinopathy,
I fully agree with
you. The disease of the old is completely different than patellar tendinopathy.
Patellar femoral arthritis.
Also Osgood scatter.
Yeah, Osgood scatter is a different entity again.
A lot of them is lower patellar tendinopathy.
Yes.
See, the thing is, in younger children, I don't know what Nicola feels. I feel there is a lot of imbalance between the front muscle as well as the back muscle. That means there is a tightness of the hamstrings and tendo Achilles. Is that right?
It is possible that way. What I can tell you is that one of the things that we were thinking about, and that has been proven, that we have shown not to be associated, is the fact that a pronating foot is not associated with patellar tendinopathy. So what we've been told in the past, that essentially a pronated foot was not allowing proper distribution of forces in the lower limb. Paradoxically, what we found is that a pronated foot was not at all associated with patellar tendinopathy. Flexibility is always an issue, and also the HQ ratio, the ratio of strength developed between the flexor and extensors of the knee, can be a problem. But there is so much literature which is contrasting over there that it is impossible to really formulate good, clear recommendations. Dr. Milind, I think you wanted to...
What percentage of people, athletes, get treated, completely relieved with conservative treatment, and what percentage needs surgical treatment?
Now, if you look at, again, the studies coming from Sweden, they will tell you that the vast majority of patients benefit from eccentric training. The reality is that it's not so. And in real life, I've never seen any group which was able to reproduce those Swedish studies. So they say that more than 90% patients benefit from it. It's not true. In real life, I tell my patients that at best, they get about 60% chance of getting better. At high level, probably only 40% of patients will get back to relative normality, allowing them to perform at the same level as before. The reality is that if the condition is diagnosed in season, while, for example, they are in the season, in the football season, no matter what you do, no matter how much physiotherapy you throw at them and so on, they will not get better. They will, even with very, very high level of input from our rehabilitation specialist colleagues, they will at best balance the whole thing, and they will be able to continue to play, but they will not get any sensibly better.
Now, the second question is surgical treatment. Now, in surgical treatment, you went from open to arthroscopic, and I don't know how happy you are and where you stand now. And
no,
what
I said I went to open. I went from open to arthroscopy, and then back to open.
Okay. So, now, what do we do in open? What do we do in open? And what do we do in arthroscopy?
It is possible. Sorry, I I thought I made it clear in my during
Do you
my
have a
presentation.
video to show us? Do I have a video to show us?
Sorry, do you want
Do you have
me
a
to show it
video to
again?
show us the operation?
Okay, I'll try and show it to you again.
Nicholas, Milind wants to ask something.
Yeah.
Oh, sorry. Let me just go back. Let me just go back to the relevant slide. Can you see the screen?
Yeah, we can see.
Yeah, we are seeing it.
Okay, hold on. Let me just go back to what.
You describe the procedure.
No, video to see the arthroscopic procedure.
Yeah, so you want, okay, let me go. Okay, I put the slide on the open procedure. Okay. So in the open procedure, I always do an arthroscopy, okay, to make sure there are no occult intra-articular pathologies that even
Can I
the
just
MRI
ask you here, what exactly you look for when you do arthroscopy?
I just do a balance of the knee because I want to make sure that I do not have intra-articular pathology, which even an MRI was not able to identify. Okay.
Because there are reports that people do some amount of denervation around the patella. There are studies.
Sorry,
that people
I'm talking about open surgery here. Okay.
Yeah.
So
in arthroscopy,
when I do open surgery, I do an arthroscopy,
yeah,
not to take care of the patellar tendon, just to make an intra-articular balance of the knee. So I'm not talking at all about management of the patellar tendon here. Okay. So I've done my arthroscopy. I've done now a midline incision extending from the lower pole of the patella down to the anterior tibial tuberosity. You can see here that I marked the area where the pain was. At this stage, I will have excised, therefore, the patella, the paratendon over there. I will have separated the patellar tendon from the Hoffa's body. Okay, so with a pair of scissors, for example, I can go behind the patella and at the interface between the patellar tendon and the Hoffa's body and separate the two. And in this way, essentially, I am denervating the patellar tendon by definition. I then make this is one of the longitudinal tenotomies that I make. Normally, there are 3 longitudinal tenotomies. You can see one here and you can see one here. Then sorry, this doesn't show terribly well, but I identify the area of tendinopathy and I excise it. And look, and I then retract the area of tendinopathy and between the tenotomies that I performed in order to have a look inside. And then I close it. In the patellar, in the arthroscopic procedure, which I tell you again, I do not undertake any longer, I go in, okay, and I take away the Hoffa's body at the interface between the Hoffa's body and the tendon. And therefore, from behind the tendon, I expose the lower pole of the patella and I niggle away at the area of tendinopathy. Make sense?
Take out the small portion of the Hoffa's fat pad.
Sorry, say again?
So you take out small portion of the Hoffa.
Yes, I do. Yes, I take away part of the Hoffa's body. And again, I take away one of the areas that can be inflamed and cause symptoms that way. I also told you that we do, what is it? Ultrasound-guided percutaneous longitudinal tenotomies. In this case, we locate the area of tendinopathy through ultrasound, okay? And we inject local anesthetic on the skin, and then with a single stab wound, as big as an arthroscopy wound, we penetrate the tendon, okay, in anterior to posterior, and we do a longitudinal tenotomy along the tendon. In this case, we do not, by definition, excise the paratenon, we only incise the tendon. If there is any doubt that it is a paratendinopathy with a tendinopathy, the results of this operation are bad because the paratendinopathy keeps on inflaming and constricts the tendon and it's a tragedy. So only do this particular procedure, which is the percutaneous ultrasound-guided longitudinal tenotomy, if there is no evidence of paratendinopathy. Okay? Is it
Yeah.
okay?
Yes. We are absolutely fine.
Back,
I think.
Let's go back. Sorry, let's go back to the full screen now.
Yeah.
Why can't I see you? My fault.
How
Stop
often
share.
you
Stop
have
share. Stop share. Okay.
Yes.
Can you see
how
me again?
often you see
Yeah. I think we should go on to the discussion of the cases. Nicola, we have last time we are supposed to discuss 2 cases on tender Achilles tendinopathy. Milind has got some cases, so we want your opinion.
I can only discuss one because I got another webinar to go to.
Okay. So Milind, quickly in 5 minutes. Yes.
Yeah.
Okay, Milind, can you share your screen?
Yeah.
Are you able to see my screen now?
Yes, beautiful.
Okay.
All are unmuted, so people can contribute.
Right. So actually, we have 3 cases. First 2 cases are actually on pre-insertional tendinopathy of tendo-Achilles dealt with by endoscopic calcaneoplasty. And the second one is of insertional tendinopathy with avulsion fracture of the calcaneal spur with coexistent Haglund's disease. But since we are talking about patellar tendinopathy today, I'll present the third case.
Don't worry. Let's have a look at these cases. Don't worry. Okay.
So I'll have to just go back and
okay, you can go back.
Yeah. So I'll do that in a while.
Yeah, don't worry.
Yeah. It will be interesting to see those cases.
Yes. They are very regular cases we see in clinical practice, and I'm very sure people will have more and more opinion on it.
Sure.
in the meantime, can we ask some question?
Yeah, sir. Only one question, because I think we are very less time.
Is there a genetic predisposition to this,
Nicola?
Yes.
Have you identified?
We have together with the group from Barcelona Football Club, we have studied some genetic polymorphisms for all sorts of extracellular matrix proteins, and some of us have sort of inherited the wrong genes. They seem to be predisposed to developing more soft tissue injuries. It is not the classical collagen genes. It's collagen 5 alpha 1, which is a globular collagen instead of the longitudinal collagen that we see in the collagen type 1 that we see in tendons. And elastin can play a role as well. But have a look. If you do a search with my name, you will find several papers in this respect.
Yeah.
Okay, should we go to the insertion tendinopathy?
So what I'll do is I'll present 2 cases in quick succession, so that Dr. Nicola can have a look at both of them and can comment on them, and then we can discuss that.
Yes.
With the presentation, the case number 1, that is insertional tendinopathy. Just to recapitulate what we heard from Professor Nicola last time, that 25% of all Achilles tendon pathologies, they are tendinopathies. They are classified as insertional, pre-insertional, which is essentially a retrocalcaneal bursitis, and superficial calcaneal bursitis. Pre-insertional is basically Haglund's exostosis, which is clinically characterized by pain and tenderness at the posterior superior side of the calcaneum, where a calcaneal prominence is often felt. The Haglund's disease and the other conditions, as the superficial Achilles bursitis, are different in terms, causes, histopathology, prognosis, and treatment. This is what we heard last time when Professor Nicola spoke to us. Insertional tendinopathy is located at the insertion of the Achilles tendon onto the calcaneum, often associated with formation of a bony spur and calcifications at the insertion site. Mafulli, he himself suggested the name for this clinical syndrome as tendinopathy. The retrocalcaneal bursitis may be combined with insertional Achilles tendinopathy, and both these conditions may coexist.
Sorry, guys. Can we speed up because they're calling?
Yes.
Yeah, sorry.
Yes.
Yeah. I know that in 10 minutes we have to start. Okay, bye.
Yes. So finish in 10 minutes. Don't worry.
Yeah.
Sorry. Yeah.
So case 1, pre-insertional tendinopathy. Clinical features: a patient is a 40 years old male with moderate obesity, complaining of pain and swelling in the left retrocalcaneal region. X-ray and ultrasound of the ankle were done and was diagnosed of having a Hageland's bump with retrocalcaneal bursitis. Ultrasound was done to rule out intratendinous calcification, which for me is a contraindication for endoscopic calcaneoplasty. He was given a 6 months of conservative treatment, but there was no improvement, and his Fowler-Philip angle was 71. What is this Fowler-Philip angle? So this is an angle in relation of the inferior calcaneum to the posterior calcaneum. Normally, it should measure around 44 to 69 degrees, and any values which are greater than 75 are designated to have a Hageland's deformity. Rush described the influence of calcaneal inclination angle in combination with the Fowler-Philip angle, and they had a positive impact on retrocalcaneal pathology, with Vega et al. Correlating this to a more than 90 degrees of this angle having a Hageland's deformity. So this is how you calculate a Fowler-Philip angle. These are two lines you draw, and if this angle is more than 75 degrees, then you probably say that yes, this patient has got a Hageland's deformity. This is the angle of the rush. You draw another line which defines the angle of calcaneal inclination, and if this is more than 90 degrees, then you almost diagnose a Hageland's deformity. Now, in this particular case, as this patient had a moderate obesity, what we normally do is, I have not more, but then about 25 case series of endoscopic calcaneoplasty. I normally do it in a prone position, but since this patient was pretty obese, the anesthetist was against putting this patient to a prone position. So we did this case in what is called as semi-floppy or semi-lateral position, and we used two lateral portals. So all lateral portal endoscopic Hageland's excision. Those are the basic skin markings which we do. That's the edge of the tendo-achilles, that's the tip of the lateral malleolus, and then you draw a line which is parallel to the sole, and where it meets the calcaneal tuberosity, just anterior to the tendo-achilles line, you take the viewing portal, and then you have additional working portal as per your convenience. So that is how the portal is marked. That is how the scope is inserted. And we have presented this case and it has been published in JOCR as arthroscopy techniques of doing Hageland's excision in all lateral position. So that is how the video looks like. So this patient had a Hageland's bump. Fowler-Philip angle was more than 75. Now, this red thing which you see is a synovium or a bursal inflammation. On top, you have here tendo-achilles, and this is a cartilaginous cap of the Hageland's deformity. So you use a shaver which is coming in from the lateral portal itself, and what you can see here is a Hageland's bump, and that's the tendo-achilles. You get a nice view of tendo-achilles here, where you can inspect the whole tendo-achilles for intratendinous calcifications, as well as some of the tears or micro tears in the tendo-achilles. Radio frequency or whatever instrument like a scoop can be used. I normally use a small osteotome. So once you have separated this, you can identify this and just push your osteotome. This is a very fragile tissue as it is a bony exostosis. So it's not a solid bone, and you can scrape it out with any equipment which you have handy with you. I use an osteotome because I can reach from lateral to medial side, and in one go, I can take out the bump, which really does not take you more than say about 7 minutes. Once you have done that, then one can use a shaver and even a burr to just round off the edges. So this is a typical case of a Hageland's deformity with retrocalcaneal bursitis, which is a pre-insertional tendinopathy, and endoscopic calcaneoplasty has got promising results when you don't have an intratendinous calcification. So that is the post-op picture. You can see that in a post-op picture, this is the Hageland's bump which you have removed, and that is the pre-op bump which you had seen in the previous X-ray. The insertional tendinopathy of a retrocalcaneal spur remains, because this actually is not the cause of pain. The cause of pain was posterior-superior, and it was a pre-insertional tendinopathy. So that is the amount of bone which you remove. And before you end the procedure, we always have a look at it on an image intensifier so that you have not removed any part of the bump back. That is the final picture. You have both lateral portals. the skin complications have been completely taken care of. You almost don't see a scar there. So it is always better, or rather in our hands, we have found that endoscopic calcaneoplasty would give better results when it is only pre-insertional tendinopathy. Case number 2 is an insertional tendinopathy, which is a 55 years female patient, has got swelling and pain retrocalcaneal regions in 6 months, has increased in last 1 month. She is unable to walk properly. There is a tenderness over posterior superior aspect and onto the tendoachelis at the insertion of the tendoachelis onto the calcaneum. There is a small fluctuant swelling which was felt, and Thompson's test for integrity of the tendoachelis was negative. This is how the X-ray picture looked like, and there was probably a fracture of the calcaneal spur here. We got an ultrasound done for the same reason, to see for the integrity of the tendoachelis, and the ultrasound report stated that there is a focal area of hypogenicity within the tendoachelis. There is a large retrocalcaneal spur at the cranial end with minimal fluid within the bursa. Findings suggest of Haglund syndrome. So naturally, this was a case which was a mixed tendinopathy, where there was a pre-insertional as well as insertional tendinopathy. So the plan was to do endoscopic calcaneoplasty and at the same time evaluate whether the tendoachelis is intact or it is disrupted, and find for the insertional tendinopathy calcification. So this is how the endoscopic calcaneoplasty was done. This patient was done in a prone position. There, what you see is a radio frequency. That's the bump. That's the Haglund's deformity. And as we saw in the previous video, this Haglund's deformity was completely dissected out. You can see a tendoachelis there. Now here you can pass your scope across that tendoachelis. And this is one finding which tells you that probably the tendoachelis is at stake and it is avulsed with the bony fragment. So similar use of an osteotome was made here.
I do apologize. I have to leave.
That osteotome,
thank you very much.
From lateral to medial
congratulations for the endoscopic calcaneoplasty.
Thank you, Nicola, for a wonderful.
Bye-bye. Thank you.
We appreciate your time for us. Thank you.
Let me know when we can do something else together. Okay.
Adios, amigo.
Bye-bye. Adios.
Thank you.
Adios.
Bye-bye.
Yeah. Milind. Okay. Milind, go ahead.
Please continue, sir. Continue, sir.
Milind, can you hear us?
I think he's got disconnected, sir. I think. Milind, sir.
Dr. Milind?
He'll join again. I think he's disconnected.
Dr. Milind?
Sir, he's disconnected, sir. He'll join again. I think.
Milind, unmute karna. Okay.
Yeah.
Milind, we can't hear you. Please unmute yourself.
All right.
Milind?
Yeah.
We can't hear you.
Okay, I'll unmute myself.
Yes.
So this and unmute. So are you able to hear me now?
Yes.
Yeah. Okay. So I'll just we messed up with that video there. So I'll just go a slide back. And now you can see here, I'll come here straight away. So we have removed that fragment there. Now I'm burring out the edges of the Haglund's bump there. And once you have done that, I'll just make it a little faster there. And I'm burring out the residual stuff. Now what I want to show you is, now here when I pass my radio frequency probe past the Haglund's deformity there, just see in a little while, a very small part of the video remaining, you can see an inflammation there. There is a bony fragment there. So the tendoachelis has got avulsed. Can you see that? So if I lift that up, the tendoachelis has been completely avulsed. This is a bony fragment, intratendinous calcification. Normally, when you're doing a Haglund's, you won't be able to pass your scope and instrument so far towards the distal end of the tendoachelis. So top, you have a tendoachelis. This is the bony fragment, and the tendoachelis is completely disrupted. The Thompson's test was negative. So this gives me an opportunity to repair the tendoachelis and remove or excise the fragment. And that's how I did it. In the same sitting, in the same position, I opened the thing there. That's the arthroscopy lateral portal, which you can see. And that is a completely avulsed tendoachelis with a bony fragment. So this is a contraindication for all endoscopic calcaneoplasty. And then since it is an enthesopathy, I thought why not use the principle of rotator cuff repair here and use rotator cuff instruments also, where I can get a nice bite and do a double row repair. So I used a self-retrieving device, which we use it for rotator cuff repair, pushed in a suture anchor onto the medial edge where I had removed that Haglund's bump, and took bites with the fiber wires and tried to make a double row repair after excision of the bony fragment from that place. So here you can see now I've taken those sutures there, and I have done the medial row tying. So I've tied the medial row, and then I used a swivel lock anchor onto the lateral row below down. So that's the swivel lock pilot hole being made. So I'll go a little fast here as well, just to give you the end result. So that's the pilot hole. And then the swivel lock anchor goes in to have a double row kind of a repair construct in that situation. Then the retention suture wire which is left, I use that retention suture wire to suture the tendo-Achilles to the paratenon and the surrounding tissues, and the wound was closed. So this was the bony fragment which was present into the tendo-Achilles, and that was the final result. So that is how the X-ray looked like. So that is the medial row. The lateral row is a swivel lock anchor, so you can't see it in the X-ray. That is the excised Haglund's bump there, and that is the post-op result, where you can see that the wound has very nicely healed. So these were two cases of insertional tendinopathy and pre-insertional tendinopathy. So we would definitely like to have comments from Professor Nicola on this, and the cases are open for discussion.
Milind, Dr. Nicola has already left because he has to go. So I think we'll take opinion of Dr.
Our Nicola, Narvekar sir, Nishit, all experts on the panel.
Yes. Please.
I think Milind is a very nice. The second case was very nice, and I have done not many but few of England. And the most important thing is that there is never recurrence, you know. So that is what it surprises me, that even the people who are having in heavy manual work, usually there is no recurrence of this, and the pain there goes away. So any Abhay, about your experience, or Roshan, your experience?
No, I don't have a great experience of retrocalcaneal arthroscopy, but we have done a lot of. Hello, yes, Antao sir.
When you are suturing the tendon, what position you keep of the ankle? Neutral or plantar flexion?
It's whenever I'm doing a repair for this kind of a situation, I'll always keep it in slightly plantar flex position. I will not accept neutral or dorsiflexion.
One comment I'd like to make: when you did a double row repair, as rotator cuff, we have seen the necrosis because you tighten the medial row. Here also, I think same principle will allow, because even the vascularity of this tissue down is very poor.
No,
so
but the
maybe
the vascularity comes from the paratenon,
okay,
which is parallel to the tendo-Achilles. So you have taken bites in the middle of the tendon.
Okay.
Yeah,
Milind,
so it will not compromise.
Radiologists missed the tendon pathology, huh?
Sorry?
The radiologists missed the tendon rupture also, no?
Yeah. So normally that is why whenever I'm doing or contemplating a Haglund's excision, I would always send patients for ultrasound to know whether there is intratendinous calcification. Invariably, there would be some amount of intratendinous calcification, but on arthroscopy, when you are seeing the tendon, you see tendon very nicely, and you can definitely know what is the amount of calcification you have in the tendon.
What difference does it make with if there is a calcification?
Because the literature codes that if you have an insertional tendinopathy, See, these enthesopathies, what Professor Nicola also said, and what the literature says is, these enthesopathies, they have a typical behavior of having cartilage cells. That is why Haglund's deformity, you see when you scope, you see a cartilage cap on top of the exostosis. And the healing potential of these, that is at the bone and tendon interface, is not very good. So if there is an intratendinous calcification, it is naturally a deterrent for the tendinopathy to heal. And recommended way to treat these patients are to excise these calcifications and do a repair of the tendo Achilles. So that is why there was a school of thought where people used to take down the tendo Achilles in presence of calcification, and they used to reattach the whole tendon.
Some of them,
if there is a calcification, you should be wary about it, and you should definitely take a call as to just to do a Haglund's or to reattach the tendon.
So their calcification goes away, huh?
some of, yeah.
Yeah, I think we
Some
should
of-
move to the last case.
Sir, I have to ask something.
Yes, Sandeep, yes.
Sir, Milind sir, very nice presentation. I just wanted to ask, in the first case, that intratendinous
some of the reports say that when you excise the pathological tendon, you have to use semity, pass through the bone and do a formal repair. Any experience about that, Milind?
No, I don't. I have semity experience for patellar tendon ruptures. I've done about 3 or 4 of them, tunneling it through the patellar tendon and the tibial tuberosity, but not for tendo Achilles. And I think if the tendon is so bad, then we have seen a lot of patients with spontaneous tendo Achilles ruptures left alone also do well in low demand patients.
In conservative treatment, yeah.
Yeah. So
sir, we can put FHL actually in
yes. Can put FHL, but that FHL is so thin, because in open TA repairs also there are I mean, people have used FHLs to span it around. People,
yes.
I have done one with semity.
Yeah.
Sir, chance of recurrence if this if Haglund's bump has been removed, but it's not recurrence of I mean chance of patient getting pain if the intratendinous spur is left.
So if you leave, so clinical examination, again, Professor Nicola's lecture, if the tenderness is at the insertion of the tendo Achilles, that is exactly at the insertion where the tendo Achilles meets the calcaneum, and if you have a small bump there, then it is a insertional tendinopathy, and that is a symptomatic bump that needs to come out. Otherwise, patient will not feel good. But if you have a posterior superior tenderness and swelling, then it is a Haglund's with retrocalcaneal bursitis. There will be no question of residual pain.
Okay. Thank you, sir.
Can we have the next case?
Okay, so last case. Yeah. So this is a special type of patellar tendinopathy, Osgood OSD, Osgood-Schlatter disease. And this is actually a traction apophysitis, although not a tendinopathy in itself. So a case of unresolved Osgood's. A 17 years male came with complaints of anterior knee pain, both knees, left more than right. He's a state level footballer aspiring to play for under 19 India team. Pain was more on running and was unable to kick effectively with the left leg due to pain, as his playing position was a left winger. His VAS scale pain was 8 on 10 on left side and 5 on 10 on the right side. Clinically, there was about 4 by 3 centimeters globular swelling over the tibial tuberosity. It was tender to palpation. There was no warmth. There was minimal fluctuation. Patellar tendon insertion was tender. A single leg squat was painful. He had a good core strength, body balance, and limb alignment. He was given a trial of rehab for 3 weeks. He was put on a complete cessation of high impact knee activities like running and jumping. To maintain the cardio fitness, he was advised to swim and undertake a stationary bicycle. His knee was taped, ice cold compresses were started, the quadriceps stretches were started, and eccentric cord strengthening, as we talked about, a lot of eccentric strengthening or eccentric strengthening in tendinopathies, as it gives rise to increase in the matrix. Then hamstring stretches and strengthening in open kinetic chain exercises were started. The patient failed to improve with a conservative treatment. And there was an important national game coming up in next 2 months. He did not wanted to miss on that game. So looking at this picture, this was the MRI. I'm sorry, I don't have X-ray of this patient pre-op, but this is the MRI. You can see the ossicles there. So these are the ossicles. That's the black, jet black patellar tendon. That is the Hoffa's fat pad. That's the inferior pole of the patella. You can see these ossicles, they are compressing onto the patellar tendon, and they are giving rise to quite an amount of disablement and pain. So the question here was whether to continue with conservative treatment, and I asked the patient to skip the game. There could be a option of injecting a local steroid or a 12.5% dextrose, or what we call as prolotherapy. And there was also an option of surgical excision of the ossicles and put patient on rehabilitation. So if you have a look at the literature, the injection, it could be a cause of subcutaneous atrophy of the tendon, and a patellar tendon can rupture if you are trying to use a prolotherapy or a corticosteroid there. And in a professional sportsman aspiring to play for the nation, this was out of question. So surgery was the choice probably which was left after discussing with the coach, parents, and the patient himself. If one opts for surgery, then probably the choice of procedure could be twofold, as we heard in the last talk. It could be open transpatellar excision of the ossicles and debridement of the tendon, or one could do endoscopic removal of the ossicles with debridement of the tendon as a simultaneous procedure. So when you have a look at the literature, this was the paper which stated the direct bursoscopic ossicle resection in young and active patients with unresolved Osgood disease have got, in conclusion, better outcomes in selective patients. However, bursoscopic surgery showed limitation in reducing the prominence of the tibial tuberosity. It was a level 4 evidence study, and it stated that endoscopic excision of these ossicles is better as compared to the open surgery or open removal of the ossicles. So this was the paper in, again, Arthroscopy journal, where it is a bursoscopy, it is not an arthroscopy. So it is endoscopic excision, where you take a high anterolateral portal and low anteromedial and low anterolateral portals. So these are how the portals they look like. What I had done in my patient was I took a high anterolateral portal, did a knee arthroscopy to see whether there are any concomitant pathologies inside, and then went ahead and put the same scope in a different direction in a retropatellar area. So these were the ossicles which were seen once I put the scope in, and this is how the tubercle looked like. So to just orient you before I switch on to the video, that's the patellar tendon I'm viewing from the low anterolateral portal. That's the tibial tuberosity, and you have ossicles right there. So that's the video now. So my scope is inside, and now I'm probing. Now top you have a patellar tendon there. You can see a small split in the patellar tendon there. And ossicles, they are embedded into the patellar tendon. So whatever you see on whatever instrument you catch hold of, maybe a shaver, maybe a RF, or a separator which you use in Bankart surgery, should be used to deal with these embedded ossicles, because they are embedded into the parotinon of the patellar tendon, and they are almost synovialized. So you have a synovial covering over these ossicles. So I am trying to remove the synovium from there. That's the patellar tendon. You should take care as to not to violate too much of patellar tendon in that situation. There's a radio frequency coming in, and I'm gently dissecting out each ossicle from the patellar tendon. So that's the ossicle now which comes into our view. So that's the ossicle there, and I'm separating it. Since it is embedded into the patellar tendon, but it is not inside, or it is not intratendinous, the chances of injuring patellar tendon while removal of the ossicles is very, very low. Although one has to be careful while doing this, and one can catch hold of the fragment with the grasping forceps and pry the fragment out. Now I'll just go back a bit and show you. I have pushed in a needle there. Can you see that? So that's coming in through the patellar tendon. So at times you tend to get lost into this retropatellar space, and this needle from the anterior aspect into the patellar tendon will orient you back as to what you are seeing for and where your patellar tendon lies. So there, that's the another ossicle which is coming out. So I've removed the major ossicles from that situation, and that's the way how the surgery is completed. So the ossicles, one has to remember that ossicles are embedded in the tendon. If you extend the knee and work in the retropatellar space, this space opens up. In flexion, this space is cramped up. In extension, it really opens up, and more often than not, you will not have much of a problem. Combination of shaver, RF separators, whatever at hand, one can use. Intraoperative fluoroscopy plays handy, and one can know the complete removal of the ossicles from there. Placing a needle in patellar tendon facilitates the orientation. So those are the removed ossicles, and that's the post-op picture. You don't see any residual ossicles there. What you see is a small bump. Now this small bump in literature have quoted that this does not have any pain potential. Although if you want to remove it, you can just burr that off. I never wanted to do it so that I would have created a bony bleeding bed there and more surface area to create inflammation in this particular patient, as he was up for a national game and he desperately wanted to play that game. So rehab is also as important in these patients as doing a surgery. First 3 weeks, the patient was put on cryo ice cold compresses to reduce the edema. Knee flexion was restricted to 90 degrees. Immediate isometric cord sets and hams were started. The exercises were started in closed kinetic chain for quadriceps, as it is shown that CKC exercises will reduce stresses on the patellar tendon. Although you have not violated the patellar tendon, you do not want to stress the patellar tendon, which have been teased while the removal of the ossicles. Upper body cardio to maintain the cardio fitness should be immediately started, and patellar tendon mobilization in caudal direction. We talked a lot about fat pad when Dr. Nicola gave a lecture. So here you do not touch the fat pad to that extent. You don't want to take out the fat pad, because if you take out the fat pad, there could be a fibrosis and contraction of the fat pad. And to prevent that, patellar mobilization in caudal direction is of utmost importance when you have touched the fat pad a bit. At 3 weeks, double leg press, which is progressive single leg press. You start mini squats, which are done in 0 to 45 degrees of knee flexion. Do not go beyond 45 degrees, that will stress the patellar tendon further. Eccentric exercises, which have been talked about very much nowadays for tendinopathies. So eccentric cord contraction, step down exercises, lateral step down exercises, step up exercises, and then perturbation exercises for a body balance. At 4 to 6 weeks, you regain full range of motion. Quadriceps stretches. The stretches, they induce collagen production, as I said in my initial introductory remarks. And at about 6 to 12 weeks, we start with single leg jumps, forward and backward running. Those are agility drills, cutting drills, and we also start with plyometric exercises. Return to play criteria is a single hop test, which is or a Y balance test, which should be about 90% of the contralateral limb. To conclude, endoscopic excision is a reliable way to deal with the unresolved symptomatic ossicles. Technically, it's not very difficult. Knee extension during procedure opens up the space. Be conservative on fat pad. Stay away from the anterior onto the lateral meniscus. Embedded ossicles should be carefully dissected, inflicting minimum tendon violation. Thank you for your attention.
Very good case, Dr. Milind. Lovely.
Super.
Congratulations.
That is why I was, when Nicola told us about that fat pad, I was slightly, in this country, if you do something with the fat pad, then you are going to have in trouble, many times.
What happens there, fat pad always covers the inferior pole of the patella, which is also have a problem. Sometimes there's a traction spur there. Here right. It is different. Milind, yeah. I have also done this, but I use the other portal and lift up with the trocar the tendon. Then you get better space to work on. No?
Yeah. But if you do it in extension, sir, you do not need any additional equipment to do that.
Yeah, so where did you put the needle, Milind?
Needle was put from anterior to posterior, from the anterior skin through the patellar tendon, just to orient yourself. I do this for Haglunds also. So do you know where the patellar tendon is, where you know where the Achilles tendon is.
Right. No, it was very good. Like initially when you want to see the acromion, you know.
Yeah. Put in a needle.
Time and again, Milind comes with nice cases, and best thing is about Milind, there's a lot of reference, not only to the surgery but also to the physiotherapy. That's a great thing.
And also
complete presentation.
Yeah, and Milind, the thing is that your video quality was excellent.
Thank you so much.
So we enjoyed. I think we enjoyed. And tell me that how much difference it has made you after your graduation in sports medicine. About your rehab.
It's a great.
I think I'll stop the YouTube first.
Okay.